outcomes at 2 and 5 years in patients who'd undergone early nerve transfer surgery. So this is the standard patient, but we're wanting to see what happens further down the track. So again, a retrospective database reviews at our center, follow up with at 2 years, although some of these are 18 months, so we've said a minimum of 18 months, and then at 5 years. Patients who had failed nerve transfers, who we then done a revision, we have obviously excluded from this sample. We had one independent assessor. When we measure MRC grade, we do measure it from the best digit, but we don't allow donor contraction. So we don't allow contraction of the supinator muscle if we're looking at finger extension, and we don't allow the patients to use a tenodesis effect when they're pressing on the dynamometer. And we also looked at ARAT GRT, which is a grasp release test, and the SCIM self-care component. So we had 22 people eligible for inclusion, all traumatic spinal cord injuries, because a lot of our early patients were all traumatic, and we do get the trauma patients, so we are a little bit sort of overrepresented in trauma SCI. 77 nerve transfers, motor level pre-surgery C5 to 7, all complete, IC 1 to 5, mean age 25, mean time to surgery 10 months, and 50 months between one assessment and the other. We've done 19 with late follow-up for elbow extension, 20 for grasp and pinch, and 38 for spin. Again, quite small numbers. So our 2-year median for this group, because we had some bad ones in there, has taken our median down to 2. But at 5 years, that same group of patients is at 4. The 2-year weight lifted in kilograms was a mean of 0.67, and at 5 years 1.19, and the number of repetitions that they could do was 3.2 versus 4.7. So that was a significant increase for this particular group. So again, if you look at it, because again, small numbers, you look at MRC triceps at 2 years, and you can see what the proportions look like. So 16% at a 1, 37% at a 2, 21 at a 3, 26 at a 4. And everybody just kind of slides up, you know, as time goes on. And at 5 years, we've got most of them sitting in the 3 and 4 category. I just wanted to say that people worry about using the teres minor and it deconditioning the shoulder. We just want to say, sort of in defense of using teres minor, that and these are just anecdotal comments, but many of our patients who've had this transfer have moved from electric to power chairs, so they're actually using their shoulders a lot more than they were doing at the 2-year mark. I mean, my comment from Bridget was that no one's complaining of shoulder pain, so I'll just share that with you. Obviously, we're not doing a study here. And a lot of them are participating in sports, some to an international level. And this is actually, one of the first videos I showed you in the other presentation of the young man reaching up and grabbing the water bottle. This is him, he's now in the national team for wheelchair rugby. He was an elite footy player before he was injured. In terms of hand opening or spin, when you're using our crude MRC, you know, they all do well. So by 2 years, they're all looking pretty good. And by 5 years, they're still looking pretty good. So no significant change between the one and the other, but that's because they did well to start with. Web space is 95 millimeters, median at 2 years, and they've got a little bit more, another centimeter and a half by the 5 year, but not a significant change. Can't say that statistically that is significant. Grasp and pinch as well. So FDS, FDP at the 2-year mark is, and I've just put FDS in there because sometimes we have transferred brachialis into just FDS. For both grasp and pinch is 4 at 2 years, and again 4 at 5 years, although the statistics buffs will notice that the IQR has gone from like 4 to 0 for FDS, which means the spread around that 4 is diminished. So many more people actually solidly sitting at 4, even though the median is the same from one to the other. So no significant change because it started off good and it stayed good. But it's still improving because grip strength is 3.1 kilos at 2 years. and at 5 years it's 5.2 kilos. Lateral pinch stays about the same. I think what we get with the thumb we get. Again, I think it's that's a degree of denervation that we're getting. And then I just want to kind of almost highlight, and I don't know, maybe the therapists can comment on this, the pinch between the index finger and the middle finger, which I think patients do use, especially for writing and things like that. And I think that's a function of grasp strength. And so that is also going up. And it's maybe a method of pinch that we should maybe talk about more, because it really is very useful to the patients. But even though that went from 2.5 to 4.2 kilos, not significant when we tested it statistically. ARAT, GRT, and SCIM. So ARAT went up from 29 to 35, and GRT from 71 to 95. I can see the trend, but unfortunately it's not significant. SCIM self-care stayed exactly the same. This is just to show you, now I've separated out the brachialis to AIN from the ECRB to AIN, and you can see that, you know, grip strength for both groups has gone up, but ARAT in the brachialis to AIN is actually significant. So that maybe trend that ARAT was looking like it was going to improve, maybe we'll see that actually shown in a bigger group. But you see how much worse these guys are off to start, you know, 18 versus 30. You can improve them more in a way with the higher level injury patients. Here is a patient who's having his 6-year assessment, ECRB to AIN and a spin. He's now 6 years post-op. I mean, that's just to show you a picture of a patient who's 6 years post-op. It's nothing more than that, really. And then on the other side, just again, because it's interesting to see the difference, this is a tendon transfer hand. Our limitations or weaknesses of the study were that our 5-year follow-ups were done within the confines of the pandemic limitations, and we were very locked down, particularly in Melbourne. So some of our follow-up times were a bit variable because we couldn't actually get patients there in person. And a lot of the patients commented that they had lost condition over the COVID-19 period, and some of them actually reported that they weren't as strong as they had been a year before. So unfortunately, I think maybe if COVID hadn't happened, we would have seen more of a improvement. I mean, I don't know that, but they certainly weren't getting the same, you know, opportunities to exercise and do therapy over that period of time. And of course, again, a small sample. Again, a few just anecdotal comments, you know, speaking to these patients a longer time after their reconstruction, that at 2 years, patients are still asking what else can be done. At 5 years, as a general comment, people are more settled in to their disability. They're settled at work, family, and their social life, and they're generally much happier, and they're really not interested in coming back for you to tweak something or add something. They're sorted, really. Just again to stress that power and functional ability doesn't always increase independence, and often those with less support are the ones that are doing more for themselves. Not to say that we should support people less, obviously. It's just like need will determine what you actually can achieve. So what I can say that in this study, between 2 and 5 years post-nerve transfer, that we observed an improvement in MRC grade of triceps power, that we did not see any MRC change in grasp, pinch, and hand opening, because we went from 4 to 4, but grip strength did improve. ARAT and GRT scores increased, but they were not significant other than in brachialis to AIN as a separate group, and there was no improvement in the SCIM self-care. Thank you.